Hi everyone. Welcome to another Wednesday VMR. Sharmin here. So good to see you all. Thank you so much for joining us. We appreciate it. I have the distinct pleasure of discussing this case with the one and the only Manaswini. Thank you so much for being here, friend. How have you been?
Hi everyone, I'm Manaswini. I'm so excited to be here co-discussing with Dr. Sharmin. Sharmin's such an amazing doctor and an amazing person, and she's made me feel so warm and welcome here. And I just want to mention how she reminds me of Judy Hopps from Zootopia, always so positive and optimistic. So I'm really excited to be here, and also it's Magnus's case. And Magnus brings such cool cases to CPS. So excited for this one, and yeah, looking forward to it.
Oh, you're so kind. Thank you so much. I deeply appreciate that. And I'm super excited, because the same things can be said about you. With that positive, beautiful, radiant smile. So I really appreciate you. Magnus, thank you so much for presenting a case. Big shout out to David and Kritika for doing scribing and teaching points. If we can get the board up, we can get started.
Yeah, for sure. Thank you so much for the opportunity to present the case to Shamin and the one and only Manaswini. I think you've really become such a huge part of the academy in such a short amount of time. It's really such a pleasure to have you. This is a case that I saw in a primary care clinic a few years back. And it's a 42-year-old man who presented actually with no specific complaint, but asking for a routine checkup due to a concern for vitamin deficiency. And the labs revealed that he had a hemoglobin of 11.9, which is slightly low. So maybe I'll just hear what questions you would like to ask and how you would approach that problem with that information.
I love this, Magnus. This is a little bit unique in the way we do things. So I'm very intrigued. All right, Miss Sweeney, what do you think? So it sounds like, there's a 40-year-old gentleman who's like, well, the biggest concern is like vitamin deficiency and discovered to be a little bit anemic. What thoughts you have and what questions you would want to ask?
First of all, Magnus, what an amazing start. So atypical as always, like Magnus. And this is a middle-aged man, and it's quite strange that he's coming with the vitamin deficiency he's suspecting. So the first thing is, it's rare to find, it's unlikely to find a middle-aged man by coming to the approaching the primary care by all by himself. And secondly, I wouldn't like to anchor to a diagnosis per se right away. So it's important to explore what is happening, if he's experiencing any symptoms, probably chest pain, or like he feels fatigued or weight loss, or if he's having any urgent symptoms that we need to attend to, probably headaches or like a fever that he's been having, or and also his dietary habits would be important to note. And we know that his hemoglobin's 11.9, which may be in the low normal to low. So again, symptoms like if he's having fatigue or headaches, or if he's having palpitations and so on, any bowel changes that he's been experiencing. Yeah, that's what I would like to ask. And also if he's and how he's doing on that day, and what makes him so concerned that he's come to the hospital, come to the primary care. Would like to hear your thoughts, Dr. Shah.
Yeah, that's awesome. Totally agree with you. I think like, in the scenarios where, sometimes like the chief complains, I'm not sure the context of it. The job is to get more context. And I think this is the time and the beauty of primary care doctor is that they get to do this quite frequently. It's just asking like what concerns you? What makes you worried about vitamin deficiency? To better understanding what their concerns are. Because, oftentimes in primary care, and well, I'll take it with a grain of salt, I haven't been a primary care doctor in years. oftentimes we go in with our own agenda of like, I need to make sure they got their colorectal cancer screening, they got all their vaccines, we like done our screening labs. And oftentimes people come also with their own level of concerns that they would like to be addressed. So agenda setting right up front is really, really important and getting a sense of why he's so worried about vitamin deficiency, what's behind that. Is going to help, build a good relationship and also making sure his concerns are addressed. So I loved all the questions that you were thinking about, in addition to kind of getting a better understanding of like why is he concerned so much about vitamin deficiency? All right, Magnus, back to you.
Yeah, I love your thoughts, both of you. So as you said, I talked a little bit more with him, and upon questioning, he told that he had actually experienced an unintentional weight loss of 6 kilo over the past 2 months or so. And he also had experienced some night sweats, chills and fatigue. And then nasal congestion and pain over both cheeks for a few months also, which was not responsive to nasal steroids. There was no epistaxis though. And in general, the Reua systems was negative for any abdominal pain or changes in bowel habits or melena or hematochezia. There was no shortness of breath and no chest pain. He also had no urinary symptoms. And his past medical history was only notable for hay fever and then guttate psoriasis, which was diagnosed about 3 months ago when he developed a red circular lesions, I would say, on both lower limbs. And he was referred to a dermatologist at the time. Who made the diagnosis, although I don't think that a biopsy was performed, to my knowledge. And the lesions also disappeared after topical steroids. And in terms of medications, he's only using his corticosteroid nasal spray. His family history is notable for type 2 diabetes, psoriasis, and ischemic heart disease in his mother. For social history, he works as a sewer worker with drainage, and he lives with his wife and their 2 children. And in terms of health-related behaviors, he's a non-smoker. He does not drink alcohol and takes no drugs. And he has been traveling to the Vietnam about 3 months prior for vacation, and then South Africa about half a year ago. And that's it for the second aliquot.
Wow, that is a rich article, Magnus. Thank you so much for getting this history and also presenting this case. All right, Manaswini, what are your thoughts? So we got a lot of information, a little bit more HPI in regards to what else has been going on for this patient and some past history. How does it kind of change how you've been thinking about him?
Right. This is a super rich aliquot. So something that's very evident in this is the underlying vulnerability the patient has. We thought he was a healthy man, and then he came to the PCP thinking it's a vitamin deficiency, but it's clearly more than that. He's been having night sweats, weight loss. I think that's really concerning. So it's important to explore what might be exacerbating such a scenario, or what might lead to something like this. So first, I would think of infections, because he's been having nasal congestion and pain over both cheeks. I wonder from when, but he's been having 2 months of weight loss. And first, I would think of whether 2 months of infection might be a bit of a stretch, might be chronic, but it's important to think of infections. And he has psoriasis diagnosed 3 months ago, and then 2 months ago he's been having weight loss. So probably an underlying autoimmune condition. We know that the seronegative spondyloarthropathy, like the pair that we know of, the HLA-B27, I wouldn't jump into diagnosis right away, but psoriasis comes in that category, and that we know that it's associated with inflammatory bowel disease, but we don't see a history of diarrhea or constipation and so on. We only see unintentional weight loss. So I wonder if it's connected to that in some way. He's been having hay fever, so I think he's susceptible to hypersensitive infections and so on. So I would think of probably a chronic infection or like a granulomatous condition, perhaps, where we have there's also nasal congestion, so something that might be infecting the sinuses and blocking and eventually causing a systemic infection. So also it's important to see if it's a localized infection that's causing systemic symptoms or something that's all in his body, in his blood, that is causing these conditions. So would like to get labs done and see what's actually going on in this patient. But in the meantime, addressing his concerns right away. So, yeah, and getting the labs done. So, infection, infiltration, neoplastic conditions, perhaps. So, important to get imaging, or an endocrine condition. Important to get his adrenals checked if he's feeling tired and so on. Yeah, these are my thoughts so far. And autoimmune workup. Yeah, and he also has a travel history, so interesting to find out if there's anything that precipitated this, or his yeah, in those lines. Would love to hear your thoughts, Dr. Sharma.
Oh, beautiful thought. I love how you like went through all the symptoms and tried to kind of see what story is trying to tell, picking out like kind of like these B symptoms of like weight loss, night sweats, and kind of establishing the chronicity of it. Sounds like this is something that has been going on for a while and how that informs us moving forward. And yeah, I totally agree with you in terms of like infection, they kind of like our inflammation buckets of being worried about like potential infection or autoimmunity, given like this kind of rashes that has been described that was responsible for steroid. Really, really great job. And I agree with you. I'm like worried about this patient. It sounds like he's experiencing some like B symptoms in a setting of like weight loss, night sweat, chills. And B symptoms are quite non-specific, which just tells you, okay, the body is a bit inflamed. So the question is like, is there any center of gravity for this case so far? Maybe. With the nasal, the pain over the cheeks, kind of brings out kind of a sinusitis type picture, possibly. Oftentimes, like more like fungal sinusitis, chronic bacterial sinusitis can present more indolently. I don't think it explains the weight loss. I would not anticipate that. But one scenario could be it offers us a clue, as you mentioned, to maybe another disease. Like, what if with a history of family, like a diabetes in the family, has he developed type 2 diabetes? And is he more like immunocompromised? So I think like those tests would be very informative, making sure to get at least like a HIV test, a hemoglobin A1C, to see like what is kind of the substrate that all of this is coming out in that context. Um, and the other thing about that is like, with nasal congestions, autoimmunity, like vasculitides, all the things that oftentimes comes up. Not that ready to quite go there as much as I love vasculitis. But again, I'm just like, stuff here, concerning. Um, in terms of like the travel history, and I think like one thing about the rash. Rashes are tough, and I think I wish I every day I wish I was better at dermatology. But I think like one thing to say about this rash is that it sounds like it had a psoriatic appearance, is that it was like kind of like circular, and not knowing and not having seen that rash. I would just say like this is a steroid responsive rash. Like I think whether this was like maybe erythema nodosum, was it hives, was it a psoriasis? I don't know, and I don't know how it quite fits in the story yet. Whether that is a part of the kind of inflammatory syndrome we're seeing, or this is something separate. So it would be interesting to know on exam, like if the rash is still present, has it evolved, has it changed? I think like whenever people have present with psoriasis and present with more inflammation, just making sure they don't have any arthralgias. They oftentimes affects like kind of the smaller joints. So something to kind of watch out for as we're like doing as we're doing an exam on this patient. So where am I? I'm worried about, as you mentioned, kind of like a more indolent infection. I'm worried about malignancy and like kind of thinking about like, oh, this patient came in a little bit anemic. Great that they don't have any melena about any hematochezia, but something that nowadays we're seeing in younger ages like colorectal cancer. So making sure we get that, at least like the fit testing done to make sure he's not losing any microscopic blood. And oftentimes, like, lymphoma is also really good at presenting with like kind of this time and type 2 symptoms. You mentioned the travel history. It's always hard. Like it's a Pandora box, right? Or like, oh, is this related or not? But a couple of things, TB, endemic mycosis, parasitic, travel-related infections that are more indolent, like, from like schisto, atomioidosis, or listeria. However, I think like unless we get more signal when we're doing the lab work, we're going through the exam, I'm not yet ready to spend a lot of cognitive energy on the travel unless we get a bit more a signal on it. So I think a really, really good exam would be helpful, and also like some basic labs. So regardless, like if there's any other involvement, any or other organ involvement, are we going to see EOs? Does this patient have a leukocytosis? What is the other cell lines doing? I think that would be really helpful. Any other thoughts from you before we give the mic back to Magnus?
Oh no, you summarized it really well, Dr. Sharmin. Yeah, I would love to see the labs, especially HIV and infections and so on, and rule them out. RPR, HIV, CMV, EPV, perhaps, even though he's a bit old for that, but definitely rule them, get infections out of the way, and then progress on the case. You summarized it really well.
All right, amazing. Moving on to the physical exam. In general, it was quite unremarkable. He had normal vital signs. He was afebrile and no acute distress. There was no lymphadenopathy appreciated on exam. And both heart, lung, abdominal, and skin exam were all within normal limits. And in terms of the basic labs, his hemoglobin was 11.9, as you know, with a normal MCV. And his baseline hemoglobin was normal, but that was like years ago since he had the last one. And his leukocytes were 4.4, with neutrophils at 3.1, lymphocytes at 0.55, which is a bit low. EOs were elevated at 0.83, so mild eosinophilia, and then monocytes were normal at 0.33. His platelets were 156. Electrolytes, renal function tests, LFTs, and TSH were all normal, and his hemoglobin A1C was 6.4%, so just below the cutoff for diabetes. And his CRP was normal. And that is it for the third L quad.
Oh, I still don't know how to mute and unmute, and how many years have been using Zoom? All right, so we got some exam and labs. What do you make of it?
Yeah, so in this we have a physical exam and lab. So we don't have any lymphadenopathy that we see in this patient, something that I was curious to know about. But again, we can't rule anything out. So in this, what would change would be not much actually. Like he has eosinophilia, like mild, probably due to the hay fever that he has been having, or the history of hay fever and his susceptibility to infections like hypersensitivity infections and so on. And his TSH is normal. I'm curious to find out his infectious workup and and his WBCs are normal. I was curious to see if he had a leukocytosis, a lymphocytosis perhaps, but not. So I'm curious to now know if he's been having a chronic inflammatory state. So that might have predisposed him to what he's been experiencing, an anemia, a chronic inflammatory um, anemia, chronic disease, so his trending of his hemoglobin, and if he's been having increased hyper, like sneezing or any infection, I would say hypersensitive symptoms, a rash that we haven't seen yet, something that might be brewing. So we don't know at which stage of his disease he's presenting, if he's been if it's something that is going to evolve or it has already evolved. So would be curious to know about that. And yeah, would like to hear your thoughts, Dr. Shan.
Yeah, I totally agree with you. Sounds like, on exam at least, like we didn't identify any lesions that we could possibly further investigate. And as you mentioned, like, the not presence we didn't find any lymphadenopathy. Sometimes like that doesn't mean this patient might not have any visceral lymphadenopathy that we just haven't captured. But for sure, like, not having any big lymph nodes make us a little bit more reassured. I'm curious about the breakdown of his WBC. So he has like a mild lymphopenia and like a mild eosinophilia. And also, I'm like curious, and the steroids were just topical. So it's something that I just like wanted to ensure that, like, oftentimes if he had oral steroids and he had like a mild eosinophilia, that oftentimes you would worry that even with steroids it's not suppressed. But sounds like he used only topical steroids. So the with that, like, what comes to mind. I think EOs give us a little bit more signal of and makes us want to open that box of travel a little bit more, is that especially because we don't have any baseline to know, like, hey, is it related to the prior allergic rhinitis? Is it just atopy that he has? And this is something that, if you had labs from a couple of years ago, it might be helpful if he still had some eosinophilia present, that you're like, oh, maybe this is just like atopy, but is it infection? And I think with like travel history, the things that you want to consider, like strongy is a good thing to kind of work up, like common type of infections. Like schisto is a good one to think about. It doesn't sound like you had much like bowel changes, any GI symptoms. And also the other thing, like sometimes like TB, chronic infections, if this is eosinophilia is not related, is another one to think about. I think in terms of like vasculitides, oftentimes eGPA comes to mind, like GPA with like specialty nasal involvement, if this is not wasn't just allergic rhinitis. So. I don't know if I can make a much more progress, rather than I think now he warrants a more kind of in-depth eosinophilic workup. Oftentimes, like, EOs tends to be tissue dwellers. However, this is not as high risk and is not as high level. So kind of trending that over time would be really helpful. And the other thing with EO is oftentimes, like, we think about like, oh, whether this is kind of a primary eosinophilia or a reactive eosinophilia. And with primary, like, you get like usually the leukemias, and when it's really elevated, hypersensitivity, hyper eosinophilic syndrome, which I'm not quite worried about in this patient. It goes manifestation again. They're tissue dweller. They like to like get in and mess things up. So you get skin, lungs, GI tract, and heart pathology oftentimes. Oftentimes, most commonly, EOs represent second reactive. So is it like atopy? Is it like infection, as we talked about? We talked about cancer, autoimmune, and also sometimes like adrenal insufficiency can present with like mild eosinophilia. We don't have any vital signs for this patient. But if you're not that, it doesn't seem like, that is a concern at this point, but something to keep in mind. One thing I would do, I would get a UA in this person. I would be curious if he has some microscopic hematuria or something that points towards like potentially kidney involvement. 'Cause, kidney involvement as well if you're more worried about like kind of autoimmunity in him. And the anemia, I think at this point he's been out of care for a few years. So with a normal MCV, is it just a manifestation of inflammation that is happening? Can we just call this anemia of chronic disease? As we're investigating that, I'm gonna still make sure he gets his regular cancer screenings. I'm making sure there's no other reason, like getting an iron panel, make sure there's no component of iron deficiency anemia. Um, so I'm not sure exactly what this patient has, but I think like a little bit better travel history, and I think he worked in sewage, correct? Like kind of exposure history there as well would be helpful. I think starting an infectious workup, and also seeing if there's any other like and I think the other thing with him is like over time how this disease might evolve would be really, really helpful. Because right now I don't have a center of gravity. The one thing I would probably do, would consider doing is like imaging the sinuses if he's having issues there. At least like can that help clue us in into what is going on? In terms of the pre-diabetes, again, doesn't really confer that much immunodeficiency that would makes me worried. But it's still, he's doing as a great primary care would do lifestyle modifications, and following that would be really helpful. All right, Magnus, I'm just talking at this point. Tell us more.
All right. I have some additional labs for you. His ferritin was elevated at 1,590. His B12 and folate were normal. Transferrin and transferrin saturation were both normal, and his LDH was 230, so slightly elevated. ANA and ANCA serologies were sent and they were negative. And then he had some immunoglobulin evaluations as well. So IgA and IgG were both moderately elevated, and kappa and lambda free light chains were also elevated, but the ratio was normal. And SPAP was sent and was also normal. And blood cultures were without any growth. I'll stop here and see what thoughts you have.
All right, talking about inflammation, my friend. What do you think about the additional thoughts?
Yeah. So I think um, ferritin here is raised. So we're thinking of what I first think is a chronic inflammatory state, so something like HLH, but that wouldn't be the diagnosis itself. So what are we looking at here? Like, what is the cause of the symptoms he's experiencing and his labs? So I think one thing that I remember from our session so far is that when we see HLH, again, like not anchoring to this, but it's important to rule out whether it's multifocal. It's important to think of conditions like multifocal Castleman's, or if he's on any Jack kinase inhibitors, but which this patient is not. So I would think of something that's happening. What is causing the rise in ferritin, like what is making the macrophages store them. So I would be curious to get a scan of the sinuses done, imaging of the sinuses, and also I don't think we see infectious workup being ruled out yet. So getting that out of the way, and also probably. mm, Dr. Sharmin, I would ask you to take or pass the mic to you. So, yeah, before I come up with more.
Yeah, I think we're all like getting signals, inflammation, 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 and we're like, where is this inflammation coming from? And I think like, what is the data that we are getting at this point? So, looks like we have high ferritin. And like polyclonal hypergamma with like IgA and IgG being elevated. Again, like all of this like tells me like inflammation. I think negative ANCA makes like ANCA associated vasculitides a lot less likely, although they can sometimes present without it. The negative blood culture doesn't surprise me. It doesn't quite sound like a pyogenic infection to begin with. So I think like in terms of like what am I still considering, I think the HLH is a really, really good thought. And oftentimes in these cases, even if you're going down the HLH, is like what triggers it. And I think the two big buckets that I would worry about is like infections and a malignancy. I still think like lymphoma is not out of the picture for this patient who's coming in with like elevated ferritin. Malignancy. So I see the tube of truth in his future, both like kind of investigating nasal and seeing like if there's any organomegaly, any like lymphadenopathy that we're missing. Um, and I think like the other thing, like with the elevated ferritin in the VMR world, always like think about adult onset Still's disease. He doesn't really have the high fevers. He doesn't have the arthritis. He had a rash. I don't know if it was like salmon colored or not, but something, in spirit of Curtin to think about is Still's disease. I think in the chronic infection bucket with that travel history, I think like TB is a good one. So at least like getting a chest X-ray to make sure there's no lung pathology there. I think fungal infection with the sinuses being involved is another one still. And then with like kind of like leishmaniasis with the travel to Africa is another one to kind of think about. And I don't know if we got an HIV test or not, but I think this is a good time to make sure we have that done. Both like kind of like chronic viral infections, like from hepatitis, HIV can cause some like polyclonal elevations too. Um, so I think in further imaging and then starting to getting some of the more infectious diseases is like what I would do at this point. Making sure like TB, HIV is done, getting if possible, like getting the CT sinuses first, and then I would also um, have a low threshold to get a CT chest, abdomen, pelvis with contrast because at this point we just like need to find where the issue is. And then yeah, I think that kind of would and the infectious workup would be kind of like my next step. Wow, all of this in a primary care office, Magnus. This is incredible.
Yeah, I have to admit, not everything was done at my short meeting with this patient. But you asked for some imaging, and he did have a CT chest, abdomen, pelvis done, which showed mildly enlarged axillary lymph nodes bilaterally, along with mildly enlarged lymph nodes along the iliac arteries. And apart from that, it was generally unremarkable. There was no splenomegaly or hepatomegaly, and no signs of malignancy. He also had a CT of the face and neck that showed evidence of bilateral sinusitis involving the maxillary sinuses and also the right sphenoid sinus. And actually, that is all that you get, and then the next aliquot will reveal the diagnosis.
Wow. All right, friend. All right. Let's see where how far we can take this. What are your thoughts on the additional imaging?
Superb, Magnus. So, CT angio shows, CT contrast of abdomen, and the chest shows some lymph nodes which are non-contiguous. So we see it in the axillary, and we're seeing it in the along the artery. So I am thinking in the lines of something in the blood that's spreading and entering these lymph nodes. So what it might be. So the blood culture is sterile, but I'm curious to see if it is something granulomatous, like fungal infection that involving multiple systems, histoblasto, cocci, aspergillosis, but that would be rare. And whether if it's malignancy, perhaps, which a lymphoma or a Hodgkin's. Usually, I think the non-Hodgkin's is what goes non-contiguous and does not involve them in order. So that as well. And what we see is the lymph nodes are lighting up, as in they're enlarged, which was not palpable on physical exam. Uh, again, infections and malignancy, neoplastic or granulomatous sarcoid, perhaps. I'm not sure. There are autoimmune conditions, and it's involving the retroperitoneal lymph nodes as well. Sorry, no, the iliac lymph nodes. Yeah, these are my thoughts so far. Malignancy and infection, but granulomatous. So probably the biopsy of the axillary lymph node might show us what's going on. Also, the glucan, beta D glucan levels, if those are raised, everything might lead to fungal infection or parasites. I'm not sure about parasitic infections presenting this way. Would like to learn more from Dr. Sharmin and Magnus.
Oh, I have much to learn from Magnus as well. We all do. Yeah. I think the question here is, we have like some sinus pathology. Sounds like kind of an uncomplicated maxillary and sphenoid sinusitis. Does this explain the whole picture? I would say no. I wouldn't expect a sinusitis to have such high elevated ferritin, but I still think like ENT taking a look would be really helpful, and perhaps like getting sample and biopsy of it and treating the sinusitis. However, um, I wouldn't. I wouldn't anchor on the sinusitis explaining this whole thing. And personally, I think like getting the biopsy of the axillary or like one of the accessible lymph nodes would be really, really helpful because I think like I'm still worried about an underlying malignancy here. I don't think I have enough information in my mind to be able to I'll put my nickel down. Because like I think a couple of things that I would be worried about. I would still like kind of want to do the making sure the HIV testing is done on someone who's like coming in with weight loss, lymphadenopathy, infection to make sure that he doesn't have an underlying HIV. And then I think like at this point, like I'm less worried about like kind of HLH type, especially with like LFTs being normal, with still trying the CBC, but however, if the LFT starts going up, the CBC starts changing, then getting the fibrinogen, the triglycerides would be really helpful. I think I would, if I was the person taking care of this patient, I would send this patient to ENT. I would treat a sinusitis, and I would want to test for HIV, TB, and I think EBV, CMV testing, as you mentioned before, it's not a bad idea at all, and get a biopsy of it. So that's where I am. Any other thoughts?
No, Dr. Sharmin, I think I'm curious to learn from Magnus what this is. I if other tests, then I would probably think, yeah, I would want to know what Magnus did and how this patient, what progress we have. So yeah, passing the mic to you, Magnus.
Magnus, I can't wait to learn what happened and what this was.
All right. Yeah, fantastic job, both of you. It was yeah, such a treat listening to your discussion. And I think you mentioned infectious workup from the second aliquot or so. So now you will finally receive it. His EBV and CMV were both IgM negative, but IgG positive, consistent with prior infection. And his HIV test came back as positive. So the final diagnosis was HIV infection. And this was, yeah, this was a really good learning case for me. So the teaching points that I took away was that we should always rule out HIV in a patient with unintentional weight loss or a normocytic anemia, even in the absence of any obvious risk factors or opportunistic infections. And I think you both mentioned that really early on, so that was really spot on from the beginning. And then I think in terms of his eosinophilia, it could be from his hay fever or allergic conditions, but also learned that it's not uncommon for HIV patients that are not on ART to have at least a mild eosinophilia. I think that occurs in about 10 to 30% that I could find out. And it can occur due to opportunistic infections, but often no parasitic infection or other reason can be found, and then it's also believed to be a result of HIV in itself in some cases. And so yeah, so but the patient did really well, and he had a good outcome, and his wife was also tested, and she was negative. Fantastic job.
Magnus, what a case and what a journey. But this is such an incredibly educational case. Manaswini, any thoughts, any reflections?
Magnus, the patient truly is lucky to have you as his doctor, and you found him. You caught HIV at the right moment, and now he's being treated and doing better. I'm so glad to hear that. And yeah, what a fantastic journey! And thank you so much, Dr. Sharmi. It was amazing co-discussing with you. You made me feel so comfortable, and absolutely loved it. And presentation by Magnus, it was incredible. Thank you so much.
That
And
was a brilliant discussion, friend. Thank you so much. This is a challenging case because I think what makes this case so challenging is like, what is the signal? You know, what is it? It's like figuring out what is signal, what problem we're trying to solve, what is noise out there. When especially like the differential is so broad, it's really, really tricky to navigate that. And as a hospitalist, I have the highest amount of respect for primary care doctors that are limited in time and have to work through very complex problems. They're the best. Magnus, amazing job. Truly, the patient is lucky to have you. And I think in terms of like a new HIV diagnosis, I think as much as possible, I'm so glad the patient did well, like getting that HIV load, the CD4 count, the genotyping, and as long as you're not like starting art as soon as possible is really really informative, because what you don't want to do is that um, I think all of his presentation sounds like could be explained by HIV, but it doesn't mean he might not have an opportunistic infection or something. So I think how like close follow-up is key. And like making sure those lymph nodes are just reactive in the setting of HIV infection and doesn't harbor anything else down the road would be really, really cool. And yeah, the EOS point, Magnus, thank you for teaching me that. And I think like looking back, and like it kind of explains like kind of the weight loss, the kind of this generalized food, the lymphopenia. So like once you look back, then you'll just see the clues a little bit more, the signals more strongly. How I truly love this case. It was such a treat to think through it. Manaswini, you're wonderful. I can't wait until the next time I discuss with you. Magnus, amazing. Anything else to add before we pass the mic for teaching points?
No, thank you so much. Thank you for an amazing discussion.
Yeah, Magnus, you gotta present more cases, my friend. This is fantastic. Thank you so much, David, for scribing. And Kritika, to you for teaching points.
That was such an amazing case, Magnus, and a brilliant discussion, Dr. Shaman and Manaswini. So today we had a 42-year-old male who presented with a concern for vitamin deficiency. So his chief complaints were weight loss, night sweats, chills, and fatigue. So considering this very broad differentials, we were thinking of some granulomatous conditions, infectious causes, and malignancy because the patient had like B symptoms. We were also thinking of lymphoma. I think Magnus already mentioned the beautiful point regarding eosinophilia. So initially we were thinking like it could be probably because of the atopic history because the patient had psoriasis and also like parasitic infections or something secondary to vasculitis. But we see that even HIV could isolated be a cause for eosinophilia. And also, Dr. Sharmin mentioned this concept of primary or reactive eosinophilia. And here the patient had elevated ferritin. So we were thinking of some chronic inflammatory processes like HLH or some viral infections like EBV or CMV and fungal infections like histo or blasto or any granulomatous infections or conditions like sarcoid. And I think this was a very important point for us to remember that we should not undermine the basic things like serology. I think Dr. Shaman mentioned all along it could be HIV, and that turned out to be the diagnosis. So that was very
Brilliant summary. Thank you so much for the wonderful teaching points. Y'all are awesome. This is so fun. Thank you for everyone in the chat for your thoughts too. Sorry I couldn't keep up with it. Y'all are the best. We'll see you next time. Have a wonderful day. Bye.